Okay. Well, good morning, everybody, and welcome. I'm Rob Attaran, and as you all know, in July and August, we begin a number of introductory lecture series in interventional cardiology. These are meant to be both educational and entertaining. And but before I begin, this is for the benefit of the fellows and the faculty. Here are the active research trials within the Cath lab. There is the Women First study with Dr. Alton, which evaluates, it's an all-comer study in women with a positive stress test and chest pain. And if they have any lesions from 30 to 90%, then IFR and FFR is performed on them. And you could snap a picture of this image so that you could remember the inclusion exclusions. There is the Reveal IFR study with Dr. Shah that just commenced today, which is going to look at a computational model for angio-derived physiology assessment. And it is any patient coming to the lab for evaluation of an abnormal stress test, and they undergo IFR and perhaps FFR evaluation. And here's the slide for that. And Dr. Shah, as I said, is the PI on that. There's also the Evolve study with Dr. Henry. If you have a large vessel and you deploy a synergy stent 4.5 to 5 diameter range, then these patients can be enrolled retroactively into the study with Dr. Henry. And if you have a patient with carotid disease, the CREST trials with Dr. Mena are enrolling. Please contact him or his staff. So let's start with a little bit of audience participation. So fellows, here's a trivia question for you. All right, can everybody else hear me?
Yeah, you're good, Rob.
Right. So trivia question for the fellows, and you can comment in the chat box, but who painted the Sistine Chapel walls? And I will see if I can read your comments here. Got 20 participants. Here we go. I'm getting some answers coming in. So I hear Michelangelo. Any other takers? And that's a good guess. And Michelangelo did indeed paint the ceiling of the Sistine Chapel, but the walls were painted by a number of other painters, including Perugino and Botticelli. So moving on, we are in the business of interventional cardiology, and our program is looking for a few good men and women to help us battle coronary disease on the front lines. And perhaps this is something that could be for you. The objectives of this talk are to recap the history and development of therapies for STEMI. We're going to talk about modes of intervention, and we're going to review adjunct therapies. There are people calling in from all over the state, and we have the pleasure of having Dr. Andreas Baumbach calling in from London. So another trivia question for our fellows. What is your estimated STEMI mortality at 1 year? Is it A, 4%, B, 8%, C, 16%, or D, 20%? Please go ahead and post in the chat box. So I'm not seeing any takers. So I've got one guess for 8%, and I got 16% from Aaron and Yassine respectively. Okay, so we'll come back to that. And the other question for you is, what is the approximate percentage of anterior STEMI patients who are hospitalized with CHF? A, 5%, B, 10%, and C, 20%. And this is pre-Entresto data. So any guesses of that? First year rehospitalization with CHF after anterior STEMI. Any takers on that? So we've got 20%. We got 20%. All right, thank you guys. All right, so I think a lot of consensus on 20%. All right, so let's keep going. During a STEMI, a number of things take effect quite quickly, and there's a process in place, and this has to be carried out well and efficiently. And some happens pre-cath lab and some post-lab, and you can see the breakdown of some of those here. And many of these facets that you see have been evaluated or formally studied in one way or another. There are a number of issues that come into mind when dealing with STEMI PCI. Do we suck out the thrombus? What do we do about non-culprit lesions? Do we intervene on them? And what about hemodynamic assist devices in shock? Do they have a role? So let's look at a brief history of STEMI therapies over the past years. 200 years ago, it was thought that if you had a coronary thrombosis, you were going to die. It's a death sentence. About 100 years later, it turns out that Creel believed that perhaps it is not always fatal. And by 1912, rest post-infarct was prescribed. In fact, through to the middle of the 20th century, patients were asked to rest for around 6 weeks. Initially, some people were not even allowed to feed themselves. Now, digitalis has been around for centuries, and in 1923, Wern used it to treat pulmonary edema. Camphor and other drugs, caffeine, were used to treat syncope and heart block. Then by 1928, morphine was utilized for the management of STEMI, quinidine was used, and by the 1950s, it was noted that all this bed rest was associated with a lot of venous thromboembolism. So Bernie Lown, among others, advocated for earlier mobilization, lidocaine therapy, oxygen therapy came about, and incidentally, if you look at just this slide, morphine and oxygen that have been a staple for so long are now being questioned, and there may even be some data to suggest negative outcomes. So here is a CCU patient in the middle of the 20th century. This is Edinburgh, Scotland in the 1960s, and you can see that the patient is resting. The patient has oxygen available at the bedside, and there is telemetry on one side as well, and he has fine taste in reading material. So moving on, 1970, the Swan-Ganz catheter began to be used. Intracoronary streptokinase was tested. By the 80s, the beta blockers emerged for STEMI. And by the 80s and 90s, intravenous thrombolysis began to be used for STEMI. This was a game changer. Here is a patent application from 1969 by a Fogarty. This is for the Fogarty balloon, which is a simple but very clever device that can be advanced into an artery, the balloon inflated and withdrawn to remove clot. And in 1980, the Woods paper noted on angiography that most MI patients did have an occlusion, and they used the Fogarty balloon to withdraw clot in these patients. In a large number of them, they successfully were able to extract the clot. Another interesting finding by DeWood that's been replicated since then is that if you perform an angiogram post-STEMI within the first 6 hours, in this case, 86% of the vessels were occluded. But if you perform the angiogram beyond that time, the occlusion rate seems to be lower, and this might suggest recanalization, something that we see to this day. All right, so moving on, 1982, Hatzler performed angioplasty in MI, and by the 90s, it emerged that angioplasty had bettered systemic thrombolysis. And this is because in most infarct-related arteries, after fibrinolysis, there is still a stenosis at the culprit lesion. So PCI not only restores the flow, but it treats the stenosis as well. And studies, including meta-analyses, showed that there are lower rates of reinfarction and recurrent ischemia with PCI compared to lysis. So by the year 2000 in the US, PCI had overtaken thrombolysis for STEMI therapy. Then came other issues like looking at door-to-balloon time. We began to understand that faster balloon time was associated with better outcomes, and emerged the entire field of outcomes research to look at what we do and how to do it better. And investigators like this handsome devil devoted their lives to figuring out how to evaluate and better understand what works and what doesn't. Another important issue that will still matter and you will have to contend with is the issue of radial versus femoral access in STEMI. The Rival trial found less major bleeds if you used radial access, and that applied to the STEMI group as well. In fact, the composite endpoint of cardiovascular death, MI, CVA, and major bleed was significantly lower with radial access than femoral. Other studies like Rifle STAX, STEMI Radial also showed less bleeding with radial access. And in our lab, this handsome devil has been a champion for radial access, and this is usually our go-to access for all interventions, including STEMI. So for the and you can see that it's stump occluded. But you also perform angiography on the left system and you see other lesions as well. There is flow, but there is disease. So the question here becomes, what would you do? Would you fix the RCA, i.e. the infarct-related artery only? Would you fix the RCA and then bring them back later for the others? Or would you C, fix everything right now? Please go ahead and cast your votes, A, B, or C. Right, so I'm seeing B, fix the RCA, then bring back. B again. All right, thank you guys. So fix the RCA, then bring the patient back. All right, so this is the issue of culprit versus multi-vessel intervention. We know that STEMI patients overall have multi-vessel disease in about a half cases. And these patients do worse. So as you saw here, there are a number of approaches. You can deal with the infarct-related artery only, or you can fix everything right away, bring them back maybe in a day and do the rest, or you can perhaps send them home and bring them back in 2 to 4 weeks to do it on a different day. A number of studies have looked at this. Here are 3, culprit, Denami 3, and Prami, and these had follow-ups between 12 and a little over 2 years after. And on top is MACE, and you see where it says favors, CR favors complete revascularization, and based on these 3 trials, the finding was that complete revascularization at some point favored the outcome of lower MACE. There was a trend towards lower mortality with complete revascularization as well. Now, there were 3 trials here, but the Cochrane review of 2017 included a few other trials, and this was long-term cardiovascular mortality. And here the graph, the diagram is flipped, so favoring complete is now on the left side, and it did appear that if you completely revascularize, it is associated with better long-term cardiovascular mortality, lower. So coming on to the guidelines of the multiple societies, including the ACC, here are some of the comments. And this is the 2015 update, and it mentions that PCI of a non-infarct artery can be considered either at the time of primary PCI or as a planned stage procedure, and notes that as recently as 2013, it was a class 3. So this was a new change with the guidelines, and the fellows who voted voted correctly. I'll stop for a second, but for the faculty and everyone else on the phone, any comments on what we've talked about so far? Okay, so I'll keep going. There is thrombus in an infarct-related artery, and the natural question becomes, well, there's all this thrombus down there, why don't we suck it out? And there are catheters, some with a relatively simple design that are merely a lumen that you can advance and then use a suction effect to evacuate the clot out. It sounds like a very reasonable thing to do, and a number of studies have evaluated that. So if you see something like this, fellows, patient comes in with an anterior STEMI, you do an angiogram, and there's this big filling defect in the proximal LAD, and it's bouncing around, and naturally you're wondering what to do with it. So would you A, aspirate first, or B, you would not aspirate, but go ahead and balloon stent, etc., as you would normally? So go ahead and cast your votes, A or B. Okay, so I'm getting, I would not aspirate. I get one person said they would, one person said balloon, and aspirate if stent, it may squeeze down left circ. Every case on its own merit, and every case can be very unique. The studies that were done on routine aspiration are shown here. And if you look at the randomized trials, and if you look at the patient population sizes, there's a lot of variability. But if you look lower down here in the bottom left, the TASTE trial and the total trial were very large in comparison to the others. And so they had a great impact on the overall findings of this particular meta-analysis. But the bottom line was that routine aspiration thrombectomy, based on these findings, was not associated with a significant improvement in any of these outcomes that you see here. So the guidelines, going back to them for a moment, says that it is now a class 3, no benefit for routine aspiration thrombectomy. So they're not saying don't do it, but don't do it routinely. Any comments from the faculty and fellows about this? All right, moving on. Mechanical thrombectomy takes many forms, and there is the angiojet design. This device uses the Venturi effect to suck out large amounts of thrombus from vessels, and it can be used in the coronaries as well as in other territories. This was a single center study. This was not randomized, and the bottom line is they found that for STEMIs, compared to not using the angiojet, there did not seem to be a significant difference in many of the outcomes, including TVR, MACE, etc. And in another study, this was a randomized trial, multi-center. They used the angiojet device, and they compared it to PCI alone, and they found that it did not improve the surrogate outcomes, such as ST segment resolution, etc. And in fact, the thrombectomy group had a larger infarct size and higher rates of MACE at 30 days. So we also do not use this device routinely. Right, so moving on to the battle royal, comparing the use of the anticoagulants bivalirudin to heparin in STEMI. A number of randomized controlled trials have been performed that I've included here for you, and bivalirudin data is in blue, heparin or unfractionated heparin is in red. And you can see that there is no statistically significant difference in these outcomes of 30-day all-cause mortality in many of the trials, with the exception of Matrix STEMI on the right and Horizons AMI on the left, which favor bivalirudin against unfractionated heparin. cardiac death was found by Horizon's MI to be lower with the bivalirudin group, also significant. And 30-day MACE rates, another outcome measure, in this case, the HEAT PPCI trial that caused some controversy a few years ago, actually favored heparin compared to bivalirudin. Then comes the very important issue of major bleeding. And if you look across these numbers, you can see that heparin patients seem to be bleeding a lot more. Now, there are a couple of things to mention, a couple of caveats. In the BRIGHT study, they also received glycoprotein 2B3A with heparin. In Horizon's AMI, almost 95% also got glycoprotein 2B3A inhibitors, and that could contribute to the bleeding. The next question becomes, well, could this be related to mode of access? Could it relate to radial access? And here are the rates of radial access. So in Horizons, radial access rates were only 5.9%. In BRIGHT, however, they were much better. And in BRAVE, they were very low. So even with that considered, there seems to be a signal that, or a suggestion really, that if you use unfractionated heparin, both access site and non-access site bleeding rates appear to be higher. Faculty, any comments about that?
Dr. Attaran, this is to me. In general, are the infusion rates for the 2B3A inhibitors 18 hours, or was there, were there any studies with shorter durations?
Yeah, there were. I don't think they're shown here, but yes, there were studies. I don't think in the setting of STEMI and others, Dr. Pfau, Dr. Baumbach, you could weigh in. I know in other PCI settings, they did shorter infusions, but I'm not sure about STEMI.
Yeah, I do think that, sorry, Andres, quick note. I think that 2B3A inhibitor use is very key. So for example, in HEAT PPCI, the use of 2B3A inhibitors was pretty low. And, you know, Horizons, it was 15 or 20%. So I do think that that's a key factor in terms of bleeding rates.
Yeah, I think the same. We should comment. So this is Andreas from the Voice from Europe. We should comment that HEAT PPCI was a single center study in Liverpool thought out by Rod Stables, who said all these data that we have from Horizons are down to the fact that patients have been treated with a lot of GP2B3 antagonists, and there's a lot of femoral, which does not reflect the current practice. So what they did is a very pragmatic trial, included almost everyone that came into their high volume primary angioplasty center. Almost everybody gets radial access, and they strongly discouraged their operators to use GP2B3As. And then the difference between heparin and bivalirudin became negligible.
Rob, are you going to show the stent thrombosis rates for bival?
Yes, right on cue, Dr. Pfau. Here are the stent thrombosis data for 5 different trials. And as you can all see, and it's replicated in 3 of the studies, there is significant superiority for heparin compared to bivalirudin in the outcome measure of acute stent thrombosis, i.e. within 24 hours. Some proponents of bivalirudin have advocated continuing the bivalirudin infusion post-intervention. As you fellows come through our lab, you will see that we're largely a heparin lab, and we heparinize during the procedure and typically stop it afterwards. As you know, we participate in the NCDR database, and here is a report that one of our former fellows published looking at the NCDR STEMI database, and they looked at a large number of patients with STEMI who underwent intervention, comparing bivalirudin versus heparin. And they found, after risk adjustment, etc., that there was more stent thrombosis with bivalirudin but no significant difference in in-hospital bleeding or MACE. So let's talk briefly about hemodynamic support in STEMI. This is a big topic, but let's just skim over it at least. We know that when it comes to balloon pumps, the IABP Shock 2 trial, balloon pumps flopped. What about the Impella device? Well, I'll show you a couple of trials for your consideration. This is out of Europe. This was a retrospective study that compared the IABP Shock 2 trials retrospectively to 237 patients who received the Impella device, and there was no difference in 30-day mortality. And this was published in Circulation last year. And more recently published, a very interesting study that various people from our center, including Drs. Curtis and Desai, authored, looked with a very fascinating research methodology at NCDR data, and they propensity matched patients who underwent PCI for STEMI and shock, comparing 1,680 paired patients, Impella versus intra-aortic balloon pump. And very interestingly, they found there were higher rates of death and bleeding with the Impella device compared to the balloon pump. In fact, the absolute increase in death, and this is in-hospital mortality, was 10% almost higher in the Impella group than the balloon pump. So very briefly, we know that with STEMI, ischemia and reperfusion can occur, and both can have consequences and certain insults. And there is the phenomenon of reperfusion injury that's beyond the scope of this talk, but trials have been underway to look at ways to mitigate the harm that can ensue from reperfusion injury. But so far, much of the findings are still in process and not quite made it to humans yet, or to therapy yet. So going back to our question at the beginning of the talk, what are the one-year STEMI all-comer mortality rates? These are data that were published by one of our former fellows as well. They go out to only 2004, but you can see that overall mortality is falling for STEMI, and it is around 8% or so. So coming back to this, 8% mortality at 1 year, and 1 in 5 anterior STEMIs will go on to have a CHF hospitalization within the 12 months to come. So that was the other answer for you. And of course, when it comes to prognosis, we know that infarct size affects many things. So in summary then, my friends, PCI has bettered lysis. Routine aspiration thrombectomy has been a flop. Heparin and bivalirudin have certain nuances, but perhaps they're not quite so different as they are similar, but there are differences in terms of bleeding and stent thrombosis rates. Radial access is best. Complete revascularization is now the standard of care. And with regards to mechanical support devices, balloon pump, Impella, little or no data to support their efficacy. There are some unmet needs. What do we do about shock? What do we do about reperfusion injury or microvascular obstruction?